Good evening, and welcome to today's panel conversation on racial disparities in health and wellness. My name is Michael Delicarpini. I'm a faculty member and former dean of the Annenberg School for Communication at the University of Pennsylvania and faculty director of the SNF Padilla program at Penn, whose mission is to facilitate robust, informed, and respectful dialogue on the many difficult, contentious issues facing the nation and the globe, and across the many ideological, cultural, and demographic divides that too often keep us from effectively addressing these issues. This panel is the fourth of 13 we are holding over the course of this academic year as part of the preceptorial, which for those of you who don't know is essentially a non-credit bearing course on racism and anti-racism in contemporary America. The preceptorial is designed for Penn undergrads, but each panel is open to the entire Penn community and to the larger public. I'm pleased to say that we have over 170 people registered for today's event. The preceptorial is sponsored by the SNF Padilla program at Penn and co-sponsored by a number of other important Penn centers and offices, including the Office of the Vice President for Social Equity and Community, the Office of the Provost, the Andrea Mitchell Center, Civic House, and new student orientation and academic initiatives, all as part of the Year of Civic Engagement at Penn. While inspired by recent events such as the murder of George Floyd and the resulting protests, demonstration, and calls for change that emerged from them, this series of panel discussions is designed to explore the ways in which racism has long been embedded in our country's economic, housing, public health, criminal justice, education, cultural, media, and political systems, to better understand the root causes of this structural racism, and to identify what we have or might do to address these inequalities. Today's panel is the first of two that focus on the impact of racism on the physical and psychological health of African Americans. I should note to the audience that you can use the Q&A function on your screens to ask questions. While we won't be able to answer all of them directly, I'll leave time towards the end of today's panel for me to ask our panelists some of them on your behalf. Now we have another stellar panel to address today's issues and your questions, who I will now very briefly introduce. So if I could ask the panelists to unmute their videos now so our audience can see you all. First is J. Margo Brooks Carthon, Associate Professor of Nursing here at Penn, a Senior Fellow at the Leonard Davis Institute of Health Economics, and a Robert Wood Johnson Foundation Nurse Faculty Scholar. Dr. Brooks Carthon's research and teaching focuses on the issues of marginalization and inequities in healthcare. Included under this broad umbrella is research addressing the disproportionate risk borne by low-income individuals with multiple chronic conditions who are transitioning to home from acute care settings, the perceptions of older minorities following a hospital discharge for use in looking for ways to improve the quality of care, patient and nurse perspectives of hospital readmission disparities, and recently a national survey of 164 U.S. nursing schools to discover how diversity pipeline programs help students from underrepresented groups enter the nursing profession. Our second panelist is Dr. John Jemmott, the Kenneth B. Clark Professor of Communication and Psychiatry at the Annenberg School for Communication and the Perelman School of Medicine, and one of my colleagues at the Annenberg School. Dr. Jemmott's research focuses on culturally appropriate HIV, STD risk reduction interventions for Black adolescents, men, women, and couples, for Latino adolescents, for South African adolescents, college students and men, and for Botswana adolescents. This work has integrated qualitative and quantitative research to develop interventions that are both culturally appropriate and theoretically grounded. He's published more than 100 articles in peer-reviewed journals and has served as principal investigator for over $64 million in research grants from the National Institutes of Health. Our next panelist is Dr. Lisa Lewis, Associate Professor, Calvin Bland Fellow, and Assistant Dean for Diversity and Inclusivity in Penn's Nursing School. Dr. Lewis's research has demonstrated that beliefs, not a lack of knowledge, are the main barriers to medication adherence among African Americans, including common perceptions among Blacks that the hypertension medicines their doctors give them might be experimental or that white people may be getting better medicines than they do. Topics that I hope we can discuss as we go through today's panel. Research also finds that spiritual beliefs and faith help Blacks navigate the challenges associated with managing blood pressure. And her current research involves a study of 200 Black men with hypertension living in and near Philadelphia. She's measuring their medication adherences electronically, monitoring their blood pressure, and studying psychosocial variables such as masculinity, social networks, physician trust, depression, self-efficacy, and medication adherence, all issues of great relevance to today's panel. Our fourth panelist is Dr. Quayshawn Spencer, the Robert S. Blank Presidential Associate Professor of Philosophy at Penn. His research focuses on metaphysical problems in science, such as what is an appropriate way to define natural kinds, metaphysical problems in biology, such as whether biological populations can have fuzzy temporal parts, and whether there's any way to group organisms into biologically real subspecies, and metaphysical problems of race theory, such as whether any folk racial classification divides people into real biological groups. Among his many publications is the co-authored book, What is Race? 4 Philosophical Views, published by Oxford University Press in 2019. And last but certainly not least is Dr. Howard C. Stevenson, the Constance Clayton Professor of Urban Education in Penn's Graduate School of Education and Professor of Africana Studies. Dr. Stevenson is Executive Director of the Racial Empowerment Collaborative, a research program development and training center that brings together community leaders, researchers, authority figures, families, and youth to study and promote racial literacy and health in schools and neighborhood. He's also the director of Forward Promise, a national program office funded by the Robert Wood Johnson Foundation, to provide philanthropic support for organizations designed to improve the health of boys and young men of color and their families to help them heal from the trauma of historical and present-day dehumanization, discrimination, and colonization. Since 1985, Dr. Stevenson has served as a clinical and consulting psychologist working in impoverished rural and urban neighborhoods across the country. His research includes 2 mental health research projects, both of which are really fascinating, funded by the National Institutes of Health, examining the benefits of racial literacy. The first is PLAY, standing for Preventing Long-Term Anger and Aggression in Youth, a project that uses basketball and racial socialization to help youth and parents cope with stress from violence and social rejection. Dr. Stevenson also co-leads Shape Up, Barbers Building Better Brothers project, which trains Black barbers as health educators to teach Black males ages 18 to 24 while they are cutting their hair to reduce their risk of HIV, STDs, and retaliation violence. Really fascinating projects, Howard. So thank you all for being here, and let's get started. Now, while today's panel is focused on health and wellness, and future panels in this series will focus explicitly on the criminal justice system and on the political system, I would like to give the panelists a chance to reflect on recent events, in particular, but not limited to, the killing of Walter Wallace Jr. just a few blocks from Penn's campus, and the recent presidential election, the results of which remain contested by President Trump, and the outcome of which will have major implications for issues of race, health, and wellness in the United States. So as I said, let's start with you, Quayshawn, if you're willing. I watched a very informative video of you talking about the role of race and racism in Trump's 2016 victory. And I'm curious if you have any thoughts or reactions that you would like to share about either this current election or more recent events of other kinds. Quayshawn?
Yeah, thanks, Michael, and thanks everyone for showing up to this event. It's a very good event to have at this point in time. I guess what's been on my mind mostly this year is the interconnectedness of healthcare issues and Black Lives Matter. So my father had a lot of conversations with him this summer talking about recent events. He actually ran with the Black Panthers. He wasn't a Panther, for the FBI out there listening, but he was involved in the movement. And this was the first time I actually learned what he was involved in when he was involved in the movement. And he said he was a molecular biologist. And he worked at a community health clinic, and he taught Panthers how to do basic laboratory procedures and so forth that would reduce racial disparities in health. So I crunched some numbers, and lo and behold, we have a very, very, very serious problem with respect to racial disparities in health in this country, and it's tied to all sorts of other issues that the Black Lives Matter movement is interested in. So, for example, health disease, number one killer, Black lives; cancer, number two killer. This year we have COVID-19, number three killer. And you get down to chronic lung disease, things like asthma are actually killing Blacks at a rate that's 3.5 times higher than the police. So I'm looking forward to this discussion. I think it's a very appropriate discussion to have at this point in time, and I thank everyone for being here.
Thanks, Quayshawn. Your point about the Black Panthers and what they really did is a good one. I wrote an encyclopedic entry many years ago for a book about political parties, and learned a lot about they were really a community organization as much as they were a national political organization, though they were both. So thanks for bringing that up. John, any thoughts on the election, the recent shooting, any other issues more generally before we dive in specifically to the issues of today's panel?
Sorry about that.
That's okay.
The thing that's been on my mind the most has really been the COVID-19 pandemic and the disproportionate impact that it's had on African Americans. And a lot of it just has to do with knowledge and access to healthcare and mistrust in terms of public health information. So I'm really concerned that now with the recent news that we're having these vaccines available, and whether the community is going to be willing to take the vaccine. I have heard that one of the vaccines is produced by Moderna, and a lot of people at Penn were involved in that research. And they had trouble enrolling African Americans into that trial. Yet it's sort of like African Americans need to be in these trials to find out whether it works in African Americans. So you had that kind of skepticism. So now that we have these vaccines that actually work, how much of a big problem is it going to be to get people to be willing to take these vaccines? And these vaccines are going to be life-saving and can have a really, really big impact on African Americans who are disproportionately affected by COVID-19. So that's kind of like the main thing that's on my mind right now.
Yeah, I can understand that, and hopefully that we can dive deeper into that when we get into the topics at hand. Lisa, any thoughts on your part?
Yeah, so absolutely. As someone who just happened to find herself working with Black men about 7 or 8 years ago, these killings deeply affect me in many different ways on a personal and a professional level. There's a quote I've started using for panels such as these and other talks. And disparities have all of a sudden regained in popularity. But those of us on the panel, and probably a lot of us on the call, know that these disparities are not at all new. And in fact, one of the first establishments of these disparities, and I see Dr. Brooks Carthon smiling. She probably knows where I'm going to go with this. Was established by Dr. W.E.B. Du Bois as early as 1899 in his book, The Philadelphia Negro. And if you'll just allow me the space to read a quote in where he boldly called out the country's apathy toward the problem of disparities for what he called the Philadelphia Negro at the time. And so he states the most difficult social problem in the matter of Negro health is the peculiar attitude of the nation toward the well-being of the race. There have been few other cases in the history of civilized peoples where human suffering has been viewed with such peculiar indifference. And I'd say that quote is probably relevant in 2020. It's the quote that always comes to mind when I see another Black person killed by the police in the media. And I think it's the topic of this panel today. It's the racism, it's the bias, both implicit and explicit.
Thank you for that. Thank you for the quote, and also for reminding us that this is not a new problem, as people on this panel certainly know. Margo, anything you'd like to add?
Sure. And Michael, thank you again for inviting and hosting this panel. And of course, Lisa definitely was speaking to a near and dear, the historical phenomenon of disparities. This is not new. And, you know, for many of us who have been from an equity perspective and kind of watching COVID, I say that the disparities in COVID were perfectly predictable. If you were paying attention over the last century and it witnessed tuberculosis, HIV, and now COVID, you know, there's a trend line there. But what I wanted to respond to particularly is along the lines with Lisa in terms of the killing of Black men. And it's the thing that's been on my mind and weighing on me, particularly as the mom of 3 sons. The killing of Walter Wallace, I think, hit me particularly so because there was an underlying mental health concern. And as a nurse with psychiatric training, it was a reminder of the ways in which mental health is undertreated and mismanaged in communities of color and low-income communities. And so the relationship between severe mental illness and fatal police shootings is significant. 1 in 4 of every fatal police shooting is associated with a severe mental illness, which appears to be at least part of the case in the death of Mr. Wallace. And we know that many Black and brown individuals live in mental health deserts, which means that the proportion of mental health providers is lower than the population need. And that when Black and brown residents do access mental health services, the care is typically of lower quality. And so the concern, you know, kind of the thing that keeps me up at night is, you know, if we don't begin to address the fundamental kind of underpinnings of a lack of access and availability of appropriate mental health conditions, that tragedies like Walter Wallace, unfortunately, are likely to reoccur.
Yeah, I was thinking exactly the same thing, and I hope when we talk about what can be done towards the end of this panel, I hope we can return to that topic. But Howard, you do a lot of work that focuses both in Philadelphia and broadly on issues of some of the more stress-related concerns that involve health. But any thoughts in general about the election, about Walter Wallace, about the events that are going on right now?
Yes, and I first want to just add a little correction. The Barbershop Project was also co-led by Dr. John Jemmott on this panel.
Ah, I didn't know that.
Dr. Loretta Jemmott as well, just to update that info. I think the thing that Dr. Brooks Carthon just mentioned is really important, and Dr. Lewis, around, you know, there are health disparities in the world, but there's also these ancillary health disparities that we don't track very well. And some of that is related to what you've just said. And in a sense, you can look at Walter Wallace's scenario and the sort of those who were watching and witnessing the murder. And the fact is, you know, when we talk about solutions, one of the sort of disparities in addition that's already been mentioned is, you know, there should be a triage and sort of emergency response to the mental health of those folks in the neighborhood who were witnessing that, whether they were related to Wallace or not, right? Because it's going to trigger every mother and every parent who is worried about their child being murdered by the police. And that would help to explain why that 1 in 4 statistic that was just mentioned, you know. And I think one aspect that we're missing around health disparities, in addition to what Dr. Lewis has mentioned, we've known about health disparities for centuries. And that's usually what government folks tout as a problem with no solution whatsoever. And we just re-examine health disparities over and over again. And while I do think it's good to look at how things shift, we've got to be understanding, you know, sort of, you know, if the water is polluted, why are we blaming the fish? And then I think in some respects, the solutions around health disparities has to be around better measurement, better understanding of the ancillary compounding disparities that relate to the major ones we study, but also how are we moving the systemic barriers and social determinants.
That's great. Thank you for that. And you've really all got us into what was going to be the first question specifically about this panel, but let's try to dive a little bit more deeply into painting a little bit of a picture, statistical or personal, of what some of these disparities are. We know about COVID. We know about some of the other things that or some people know about some of the other issues you've mentioned, but they go pretty deep, both in terms of physical and mental health related issues. What I don't know, what I'd be curious about is there any evidence that this is improving or not improving over time? Does it vary by region or locale? Clearly, it must vary some degree by class, but help us and the audience get a sense of what these disparities look like more broadly and more deeply, and what their consequences are for daily life. Why don't we start with Lisa, if you don't mind? You can add to what you were saying earlier or bring up some other issues that are related to this.
Sure, and Dr. Spencer noted some of the more common chronic illnesses that lend themselves to the disparities we see in the Black population compared to, I can speak specifically to cardiovascular disease, since that's the space that I've been working in for the past 17 years. And quite frankly, it is, as Dr. Spencer mentioned, heart disease is the #1 killer for Americans in general, but particularly for Black Americans. And so for Black men, the leading cause of death, the ages of 1 to 35, is homicide. Then after that, it's heart disease. It jumps to heart disease, and it remains there through middle and older age. Hypertension is the #1 cause, the leading cause of heart disease for Americans. And so just to kind of contextualize the disparities that we see, 47% of Black women are diagnosed with hypertension. That's almost half of a population, followed by roughly about 42% of Black men, followed by white men, which is roughly about 33%, and 30% for white women. But what is even more troubling is that Black men are dying at 2 times the rate as white men. So they may not have the highs, it's Black women that have the highs, but dying at 2 times the rate. And even the language that I'm using, I think is even problematic, right? Because we're trained to present a problem so that we can offer a solution. And so even the language of they are more likely to, they are at risk, they have a disproportionate burden, inherently says that there's some biological underpinning that's causing this, or there's something wrong with Black and brown skin that lends itself to disparities. And Dr. Stevenson led us there. I'd just like to again highlight that there's nothing inherently wrong with Black and brown skin that lends themselves to these disparities. It is the social determinants of health. It is the structural inequities associated with racism that leads to these disparities in health. We see the same thing in COVID. So the last time I talked about health disparities was about 2 months ago. Roughly 8 million Americans had COVID. That number today is something like more than 14 million. And with respect to Blacks, Latinx, and Indigenous populations, the number of cases are 2.6, 2.8, and 2.8 higher compared to whites, respectively. The hospitalizations are higher by some 4.7-fold times for Blacks, 4.6 for the Latinx, and an astounding 5.3 for the Indigenous folks. We don't talk about Indigenous folks a lot, but it's an important population that's really understudied, but experience some of the most pressing disparities. And the deaths are no better across the board. So Blacks are just affected in pressing ways.
I'm struck by those numbers, but I'm particularly struck by 2 points that you made. One is that in order to get to the issues of this kind of health, you mentioned that the major cause of death among young Black males is homicide, and it's almost went over my head when you said it, and yet that's such an important thing to start with. And secondly, your point about language is really important. I mentioned before we went live with this to the panelists that the number of scholars who said yes to participating in this just overwhelmed me. But the one pushback I got was from one scholar who's not from Penn, who's going to be on a future panel, who said that my use of the word disparities had that same effect, that it was a kind of a clinical term that made it seem as if it was something out there as opposed to something that has real clear structural causes. So I confess that in my own learning over this. Howard, talk some more about some of the issues that you've looked at. I'm particularly interested in the work that you do that talks more as much about the impact of stress, trauma, psychological kind of issues as the physical ones, but they're obviously interrelated. But help us paint a picture, especially if you could say anything about Philadelphia as a city, since we're here now.
Mm-hmm. Well, I think still less about Philadelphia, more nationally, but I think Philadelphia is a microcosm of what's happening nationally. If you look at 2018, for those folks who were Black and Latino who needed mental health and substance use services, about anywhere between 44% to 69% of those adults could not get treatment and did not seek treatment for a variety of reasons. But if you look at what's happened in the last 8 to 9 months, that number has gone up to 88 and 89% for Black and Latinos respectively. And so, and what most people think of is that stigma or the minimization of symptoms is the reason why folks aren't seeking treatment. And the real reason is cost. And so one thought to consider there is that even the attack on healthcare in the society is a systemic racist act when you consider who is going to be vulnerable not to be able to receive low-cost healthcare. And then sort of, there's some research that suggests that Medicare is overtaxed, particularly by Black and brown children. And in a sense, how in the world can we consider, those kinds of needs for treatment and needs for low-cost treatment when so many are going, uncared for. And so if you add on those needs with the sort of ancillary stress attached to families, if you have a parent who's struggling with mental illness or substance use, the compounding aspects of unemployment, not being able to access resources, I think we're really under judging, we're under assessing what the cost is for families who have just one loved one with one illness regarding, and those statistics relate to an increase in depression, anxiety,
Yep.
and comorbidity. So I think what Dr. Lewis has already said, we have a lot of work to do.
Yeah. Thank you for that. John, I know that you work in a number of areas, but I've done a good amount of your work in the area of HIV and HIV prevention. Talk to us a little bit about some of that and what the numbers look like and what the circumstances are.
HIV from the beginning has disproportionately had an impact on African Americans. And if you just look at our representation in the U.S. population, we are overrepresented probably about twofold within HIV infections. And that's across the board in men and in women, men who have sex with men. In the US, it's primarily homosexual epidemic as opposed to elsewhere, like in Southern Africa. So from the beginning, you had that disparity. Over time, there have been some changes in terms of HIV and the focus of our efforts to combat HIV as a nation. So early on, it was, safer sex, use condoms to prevent sexual transmission. And when I was doing work in that area, part of what I tried to do was, not only to do research, but also to work with the community. So I did some work in churches informally, not just, research studies, just to sort of educate, health education in the church, if you will. And one of the things that I encountered was, even middle-class people, African Americans, who were really wondering whether HIV was actually as bad in the African American community as was publicized. People were skeptical. Then people were skeptical about the means of preventing HIV. They're trying to get us to use condoms because they want to have fewer African Americans. HIV was created by the CIA to have an impact on African Americans, conspiracy beliefs. So, we've moved on from there. Now we have treatment for HIV. If people take the treatment, they can live a really long life. If people take the treatment, they won't infect their partner, through sex, because they'll be virally suppressed. So now we talk about, in terms of HIV research, the continuum of care. We need to get people tested for HIV. If they're positive, we need to link them to care. We have to retain them in care, get them on medication so they can become virally suppressed. You can't detect the virus in their blood. So what do we have now? We have disparities in the continuum of care. So African Americans, if they get tested, they're less likely to be linked to care. If they're linked to care, they're less likely to stay in care. And if they're on medication, they're less likely to achieve viral suppression. So we have that going on. Those are big disparities. Now, another new thing that's happening, now we don't have to rely completely on a behavioral method of prevention, using condoms or practicing abstinence or cutting down on your number of partners. Now we have treatments, HIV treatment as prevention for people who don't have HIV. So now you can get pre-exposure prophylaxis. You take a pill every day, and if you're a high-risk person, it'll prevent you from actually getting infected with HIV. And what do you know? African Americans, although at highest risk for HIV, are least likely to be on PrEP. They're least likely to know about PrEP. They're least likely to talk to their doctor about PrEP. And given that they talk to their doctor, they're less likely to be on PrEP. So those are the problems that are going on in the area of HIV.
Well, I want to return to some of the points that several of you have made when we talk a little more deeply about both the causes of some of these differences, but also solutions. But Quayshawn, sorry, why don't you talk a little bit more about some of the disparities that you see and have looked at?
Good, thanks. I can see I'm going to offer some ideational diversity to the panel, because what I actually look at are biological determinants of racial health disparities. And we can double down on breaking out of the black-white paradigm. I'm going to mention like 3 examples of big cases in recent medicine that have shown that not doing things like appropriately racially sampling when we're testing for a drug response in clinical studies has led to differential outcomes based on differences in underlying genomic ancestry. So first example was this study in my home state, Tennessee, mixed with a research center in California, which actually was where I was born, so I went twice. And it was St. Jude's Children's Hospital in a place in a cancer center in California that was looking at differences in drug response, the chemotherapy response to the standard treatment for acute lymphoblastic leukemia in children. And what they found was, if you looked at it continuously, then Native American ancestry at even with small levels of Native American ancestry going up to 10% and then dramatically above 10% responded differently to the standard chemotherapy. And if you looked at it discontinuously, having 10% or more Native American ancestry was tied to responding differently. And we're talking about a twofold difference in whether you're going to get relapse, right? Which isn't good, right? And they did some genetic studies on these individuals, and they found that there were some alleles that were very closely associated with having a substantial amount of Native American ancestry that were also drug metabolizing alleles. So they were relevant for the sort of causal pathway that was being tapped into to address this particular cancer. And this is an important issue for people who are concerned about childhood cancers, because acute lymphoblastic leukemia makes up 3 out of 4 of childhood leukemias, and leukemias in children, of course, make up about 1 out of 3 childhood cancers. Here's another example. What about what happened in 2014 when the Attorney General of Hawaii actually sued the company that created Plavix? This is a drug that is a blood thinner. So if you're at risk of having a heart attack or even stroke, your physician might prescribe this. And it turned out that when this was prescribed, they were looking at the numbers in Hawaii, so lots of Native Hawaiians in Hawaii. When this was prescribed across racial groups, there was a 2-fold increase, nevertheless, in death from heart attack among the Pacific Islanders in Hawaii compared to whites. What's going on? They did some more studies, found out there were 2 liver enzyme genes that had alleles, like different variants of the gene, that had a hard time processing, metabolizing the particular drug that they were using to treat this illness. And now it's like sort of recommended that you actually genotype people before you try to prescribe this drug, because it turned out that also these poor metabolizing alleles actually occurred in 1 out of 4 Native Hawaiians, right? Here is a current example that just fell into my lap the other day. MIT researchers did some computer modeling to actually predict that there are gaps in the sort of efficacy that we're going to be getting out of these subunit vaccines. Now, efficacy is something that is calculated from a clinical trial. It's 1 minus the risk ratio, which we could get into all that stuff later. But what they were doing is, because we weren't sampling, we haven't been sampling enough racial minorities in our COVID-19 clinical trials. They're trying to estimate the extent to which these drugs will actually be as effective as we're being told. We're being told is 95% effective. And that's because of the population of people that we're calculating this 95% for. No one can show you that they are 95% effective for African Americans or Asian Americans and so forth, because we aren't sampling enough to even make that calculation statistically detectable. So these are just a couple examples. So with this last one, what the MIT researchers determined was that they predict that the sorts of vaccines that we're coming out with actually will be less effective in Asians and Blacks. And so this is a concern. We can talk about what one might do to improve the sort of type of drugs that we produce for different races of folks.
Yeah, that's incredibly depressing. But I want to return to that, because you started off by talking about the kind of tension that how do you talk about those things without making it sound like you've gone back to blaming difference in people, and I think it's both important and tricky. So I want to come back to that. But Margo, just in terms of general painting us a picture of the various ways in which health and wellness, both physical and mental, differ across races, is there anything you'd like to add at this point?
Sure, just briefly. And this kind of builds off of some of the themes related to Dr. Jemmott, Stevenson, and Lisa, related to not just the higher prevalence of specific chronic illnesses, but also challenges in access and treatment. And so what our team has found is that even after accessing healthcare systems, such as hospitals, Blacks are less likely to experience a good outcome, even with the same condition. And so we've noted, for example, that when older Blacks are hospitalized for a heart attack, they're more likely to be re-hospitalized within 30 days of discharge. And so, it's never good when you're hospitalized on a Tuesday and you come back on a Friday. And when that occurs, the assumption is there was a quality lapse in the original hospital admission. And we've also found that compared to white patients, Black patients are less likely to survive after experiencing a heart attack or cardiac arrest in the hospital. And so you have to imagine in the hospital, if you experience a cardiac arrest, it's very protocolized. You call a code, you start compressions, depending, you defibrillate. And so survival to discharge is very low. Only about 25% of people survive after having a cardiac arrest in the hospital, but Blacks are 12% less likely to survive. So why might that be? And so what we found is that in both cases, whether it be readmissions or cardiac arrest, that it has a lot to do about the quality of hospitals that Black patients are more likely to receive care. And in particular, Black patients are more likely to be cared for in settings where healthcare providers, particularly nurses, lack the resources to provide necessary care. And so prior to COVID, you would say, like, don't you just have resources in hospitals? But now that, some hospitals have PPE, like basic mask and gloves, and some don't. And so if you're in a hospital where nurses don't have enough PPE, the likelihood for infection is higher. And similar is the case that if you're in a hospital where nurses have 4 patients, there's a certain level risk, but it's certainly higher if the nurse has 7 patients that they're caring for. And what we're noting is that Blacks are systematically in these hospitals, and that in some respects helps to explain some of the differences that we're seeing. And I think that goes back to Lisa's point about not always looking at, individuals as being the risk factor or the disparity in and of itself, and really looking internally at the systemic differences in organization settings and providers where Black patients are more likely to receive care.
I mean, once again, you've kind of already begun to talk in great detail about the next question that I want to ask, but I want to try to parse it a little bit more and dig a little deeper into it. So talking about causes, and I've heard bits and pieces of lots of possibilities, from physiological differences that are exacerbated by the fact that we don't do testing in a way that takes those differences into account, to the quality of the healthcare and disparities based on class and race, to well-founded, I should add, suspicions about the medical profession on the part of African Americans, and I'm sure many more that I haven't even touched upon. But talk a little bit more, if you will, about what we know about why these disparities exist, and what seem to be the main drivers. And I know there'll be some disagreement, which I love, among you on what those things might be. But Howard, if you could just start us off, what if there were 1 or 2 things you wanted to say are the key components of why there are these disparities? That may be an unfair way to put it, but what kinds of things should we be thinking about? What does the research tell us?
Well, I can't wait to hear what my colleagues are going to say about this. I want to just throw in one of my struggles being on NIH panels, which I know John has done a lot of, is in the work that we're doing philanthropically, is that one cause, I would argue, is a narrative of dehumanization that folks have been socialized into, to believe that there are differences that allow scientists, even knowledgeable folks, to not care about how many people who are different are in those trials. And in a sense, for the sake of getting at larger places, in addition to the difficulty in the history of mistrust, I think we have to look at how is that narrative of dehumanization present in those who are thinking. Some of my most difficult challenges have been arguing with white scientists who are really not knowledgeable about these issues and it's not part of an educational system in which they would have to grapple with the stress of not knowing about racial politics. And in many respects, I think we need a better level of competency. So in addition to what Dr. Brooks Carthon is talking about, even the competency and the quality of the medical services, there is an element of cultural competence that is understudied as to how I engage Black and brown people in ways that they will trust and then take risks. And the barbershop example is one that, you know, barbershops are incredible educators. If you think about their ability to persuade young men, their captive audience. And the men told us many times there are a lot of places they can go in the world, but the barbershop is the one place they can go where 95% of the time they leave looking good and feeling good. And there aren't many places in their life that can happen. So part of the idea is how do you construct services that are not just competent medically or scientifically, but also culturally understanding how Black and brown, the history of Black and brown racism has affected how they engage those services.
Thank you for that. I was going to go to Lisa, but I want to go to Quayshawn actually, because this issue of how do you identify actual physiological differences among different groups in society, but not do it in a way that, makes us realize how best to study it and solve it rather than it becoming a blame game. I mean, Quayshawn, could you talk a little bit more about your views on this?
Yeah, so it sounded like one of the big concerns about looking at biological determinants of health in addition to social determinants of health, which are of course the primary determinants, is you be blaming the victim. But let me be clear. So I think Howard's ultimate explanation is along the lines of the right explanation insofar as the ultimate group of people to blame is this institution of racism, right? Now, institutional racism has various flavors in the scholarly literature. The flavor that Howard was talking about is more along the lines of like an ideology flavor. So where there's a system of beliefs about white superiority, Black inferiority, other racial minority inferiority, and so forth, that's circulating throughout society, that's causing us to behave in ways that are disadvantageous to those people in the hierarchy. But there's also this other form of institutional racism that I think is also pretty causally relevant here, regardless of what the sort of immediate sort of fixes we could make, like an immediate fix we could make to undersampling African Americans and so forth in drug design studies is to sample them more. But why aren't we doing that? We already have a law, the 1993 NIH Revitalization Act, that requires the NIH director to make sure that there's enough racial minorities in NIH funded clinical studies and so forth. So why aren't we doing it? I think this other sort of way of thinking about institutional racism from this philosopher Jorge Garcia from Boston College is useful here. Instead of focusing on beliefs motivating actions, he focuses on character, and in particular, feelings and intentions, right? This is a different way of thinking about ethics. It's from the virtue ethicists of Aristotelian virtue ethics. And the idea here is, well, look, sometimes you could just not have the right motivation to do something. You could have the right beliefs, you can be extremely educated, you just don't care. Right. And I think that's so another root to institutionalized racism for Garcia is not having morally sufficient care for people based on their race. Yeah. So, I mean, it just strikes me as like how can you look at what's going on? So some of the statistics about sort of the immediate causes that we could be doing, since the 1993 NIH Revitalization Act came into play, in the next 20 years unfolding, we've only done 1.5% of our NIH-funded clinical studies that have been focused on racial minorities. Right? Why don't we care? So in addition to problematic beliefs, I think we have problematic motivations. Yeah, we just don't care enough.
I think that argument could explain a lot of this past election that we just had as well, more broadly. That's an excellent point. Thanks for bringing it up. So, Lisa, causes, the ones we've talked about and where you stand on them, or other ones as well?
Absolutely. I mean, the access to care that everyone's talked about, absolutely really important. There are also other outside of the access or the hospital or the inpatient experience, if you will. And so there's housing, and I think this probably has relevance to your whole, to this whole, what you're doing here with the panel. I did some work with colleagues at the American Heart Association, where we found not just things like the built environment, which is sort of the low hanging fruit, access to food and so forth, but even things like housing insecurity and homelessness being directly affected, related to cardiovascular disease and cardiovascular health outcomes. Another area, not a whole lot of literature, but it's growing, I think, things like the elections. It's so timely, right? So again, the low-hanging fruit is the results of the election on not only mental health, but physical health. And that's in terms of the types of policies and so forth, but also direct links in terms of the stress associated with the recent elections, this one and the previous one, and what that does to health outcomes. Rodriguez and colleagues actually argued that even the excess mortality we see in underrepresented minority populations can have an effect on elections. So it's sort of a cycle, if you will, health and elections and elections.
Yeah.
I'm a behavioral scientist. I know Jemmott is too. And so I don't want us to lose sight. It hurts my soul. I think we definitely have to talk about structural factors associated with health disparities that are absolutely important. And I tell this to my students, to my undergraduate nursing students, but we still have to help people in the spaces and places that they currently are until such time that we can figure out all of the structural pieces, which will take us some time. And so as a behavioral scientist, I don't want us to lose sight of the individual factors that do, right? And without blaming the victim, but we know that beliefs are important. Dr. Jemmott talked about a whole host of beliefs associated with HIV and HIV medications. I myself examined them with respect to antihypertensive medications, which are some of the least experimental medications that we have to date, but still the population that I work with thinks that they are experimental in terms of being prescribed. And so the individual beliefs are really important. And I think we do have to develop interventions that address individual level factors while considering structural influences on these health disparities.
Excellent, important point. And the two are not unconnected to each other either. Margo, anything you'd like to add to this?
I would, and I think it connects to, and I'd love to have coffee with Quayshawn and hear more about his thoughts about morally sufficient care, and then with how it related to our need to develop competencies. Because both of them make me think about, again, healthcare professionals, in so much that we know that underrepresented minorities are underrepresented among healthcare professionals. And so, one of the reasons we don't care, or it appears that we don't care, is that there's an insufficient percentage of minorities who are in places to identify inequity, study them at the NIH level, and to really impact change. And that too is systemic. That is too by design. Minorities are well over 30% of the US population, but I think represent about 6% of all practicing physicians. Nursing isn't much better and still lags as well. And if we trace back historically, we know schools of medicine and nursing systematically excluded students of color. And so when you think about that, and that was for decades. And so when you think about the original historic insult of exclusion, it leads to a generational deficit in the numbers of minorities who are in healthcare as healthcare professionals. And again, we know that minorities are more likely to work in communities of color. And so we then again add to a challenge in access to high quality providers. And so I think that it is important for us to think about the ways in which our systems, I know Lisa is cautioning us to not go off the rails with healthcare systems and look at behaviors. But when I think about kind of those early historical insults and we trace them to some of the deficits that we see today, it's important to identify them so that when we begin the reparative work, that we look specifically at dismantling some of these structures that have caused some of the challenges we see today.
Great point. Thank you for that. John, a lot of these issues that were raised tie back to both your work with NIH and your point about the difficulty, even in the current COVID vaccine tests, in recruiting African Americans, coupled with Quayshawn's point about the lack of motivation to begin with. I mean, what are your thoughts about some of the major causes of the disparities that we've been talking about?
I think that the point that has been raised by Howard and also by Margo around cultural competence is key. If you want to recruit African Americans for trials, you need to know how to do that. You need to know how to communicate with the population. Otherwise, you're going to have great difficulty recruiting them. It's not impossible to recruit them. You can get the numbers for your trial, but you need to know how to do it. And you need to figure out how to do it. And that might involve doing a study to figure out how to recruit for a study, because you don't know. Then the other thing is in clinical care. There needs to be more cultural competence. There needs to be better communication. I think there's often a disconnect between the provider and the patient when the patient is African American. There's a total lack of communication. They're not given the information that they should be given, probably because maybe the provider doesn't even think of it. There's some kind of an implicit bias that's going on that affects the way they interact with an African American as opposed to somebody who's not African American. So that cultural competence needs to be addressed. And maybe because they have very little experience with African Americans in general, so they just don't know how to communicate. In medical schools, in the training of nurses, et cetera, there should be a greater emphasis on cultural competence. We can't solve this problem just by having more African American providers. I mean, we need more African American providers, but the white providers also have to be culturally competent in order to really address these kinds of problems. In terms of HIV, both here and in South Africa, I've heard the same thing from many Black patients. When they, go in for treatment, they're in the waiting room, they're dealing with the medical professionals, and they feel stigmatized. They feel that they don't care about them. These are things that are, make someone not even want to go to see the doctor because of the way they're treated there. So that is something that needs to be addressed. Cultural competence, communication.
Thank you. I'm mindful of time, but I do want, and you've all, again, in a way that I just really admire, have already begun to put on the table potential solutions, or at least beginnings of solutions to some of the issues that we've been discussing. But if I could ask each of you, are there examples of solutions along the lines of what you discussed that have been tried and actually seem to work? Or is it a matter that we haven't even gotten to the point where we can understand these problems enough to begin to try to implement solutions? And I'd like to start with Margo on this one. Anything that you've worked on or that that has addressed effectively some of the issues that we've been talking about?
So I do think that one of the ways I think we can incentivize particularly healthcare systems to care is by attaching their payment to the care they deliver. And so we know that starting in 2012, CMS, the Centers for Medicare and Medicaid Services, began to penalize hospitals for readmissions for specific conditions. So I gave you the example earlier that it's not a good thing if you're discharged from the hospital today and come back on Friday. Well, now, CMS or Medicare won't pay for that second readmission. And so what if similarly, CMS and other payers said, we want you to examine your disparities, and we're going to incentivize you for reducing them. If you do, you get payment. If you don't, you get penalized. And it's a lever, it's a carrot and a stick, but in many cases it is effective. And similarly, when I think of schools of nursing and healthcare systems, credentialing and accreditation are, again, powerful carrots and sticks. And so to the degree that diversification of your trainees and or reducing your disparities is tied to or wed to things that are ideally important to the institution, I think those might be some ways that we might be able to see some organizational change.
That's great. That's a great concrete example. Quayshawn, any thoughts on this? What might work? Any evidence in your kind of exploring these topics that suggests it does work?
Philosophers are notorious for generating problems and then leaving it to the rest of the academy to figure out practical solutions. I like Margo's idea of incentives, but I'll officially leave it up to economists. I think we've put people on the moon. I don't see why scientists can't figure out how to eradicate some of these racial disparities in health. But I'm perfectly happy to jump in and help out with some of the philosophical sort of structuring. One thing that I've been thinking about recently is what should count as the ultimate aim, because racial disparities in health per se probably shouldn't be, racial equality in health per se probably shouldn't be the aim if you want a just society, because then you might be overriding certain liberties by, sort of trying to artificially force all races to have equal health outcomes, right? So then we might want to think about what actually is the morally relevant aim that we're aiming at, and have that as a constraint to inform how we go forward.
Interesting point. Thank you for that. Howard, you've done a lot of on the ground kind of projects. Anything that you've worked on or are familiar with that you think could be a partial solution to these issues?
Well, I would definitely support the systemic racism advances, and you could argue that if everybody had access to healthcare, you could change some of the systemic racist health outcomes in a few years. Back to the question though around individuals, I think even if we have systemic racism policies that are addressing policies that address systemic racism, there's still the problem. Back to what Dr. Lewis was mentioning, that if individuals don't know how to be racially just in their behavior, we're still stuck in a particular way, regardless if the laws have changed. So part of the work, in addition to what I love what Dr. Spencer mentioned on, morality is an issue, and then beliefs is another issue. There's a third rail, I think, around the stress that people have during racial moments. They're so overwhelmed by them of doing the wrong thing, either intentionally or unintentionally. They have what of threat reactions, fight, flight, or fright reactions. And we know better now through the neuroscience research that if we can help people be more aware of their own thoughts and reactions in a moment using mindfulness, they're better at making decisions. Some of the work of Philip Atiba Goff has looked at even police officers. If you're running after somebody, stress actually exacerbates the use of stereotyping, and you're going to really make bad decisions. That some of the recommendation is the cop who is not overstressed to be deciding and talking in those moments. You could argue that if we have better ways to have folks know what's happening to them in a moment. I mean, most of the worst encounters happen within 2 minutes. If you think of police youth encounters. So how do we train folks to manage their stress in highly stressful moments to make better decisions? That would be my suggestion. And we call that racial literacy. So
yeah, that's right. I've read some of that, your work on that. That's great. Thank you. Lisa.
Yeah, so as I'm sitting listening to us speak, I started to categorize what we're talking about in my head based on the article that I submitted on structural racism. And I'm blanking on the actual authors right now, but they categorize potential strategies and interventions in sort of 3 buckets. And so there's the place-based approach where you're meeting folks where they are. And a number of us do that on the panel. And I'll share an example of how I'm doing that. There's a disruption of systems, if you will. So it's like reforming the policies and what have you. And then there's the breaking down or dismantling the racism. And that's the training piece I think we're talking about. We have beautiful examples right here about the place-based approaches through the barbershops and through the churches. I do want to put in a little bit of a plug. So Michael, you mentioned the study of 200 Black men with hypertension that's actually completed. I'm actually working on a new project right now that sort of speaks to the structural barriers to health, and it's part of the Calvin Bland Fellowship, supported by Mr. Calvin Bland, who's a Penn alum, as well as a former program director at Robert Wood Johnson and Robert Wood Johnson Foundation. And I'm doing that in collaboration with 2 colleagues, TJ Ghost at SP2 and Ed Brockenbrough at GSC. And it's an interdisciplinary diversion program for first-time offenders who are Black men. And so there's a health and wellness component to the diversion program where we're actually meeting individuals where they are. So we're not asking them to go see a provider. We're in a sense bringing the provider to them. It's a little bit on a pause right now because the courts were shut down as a result of COVID. So the first group and then the courts shut down, but we're hoping to pick that up. But that's an example of a place-based approach where the men come to the Center for Carceral Studies that TJ heads, and they get all of their services there. So there's a health promotion component, there's social services, and there's an educational component. And I think we have multiple examples of similar approaches in the literature for all kinds of health issues.
Thank you. Thank you for that. John, I want your views on what sorts of things might work, but I want to bring in a couple of questions at least before we end from the audience. And one of the questions seems like it might be something you can address. It's what communication messaging or access models exist to address the distrust and suspicion in the African-American population for the healthcare system. I mean, again, keeping in mind that some of that suspicion is based on actual reasons and facts and experience. But to the extent, as you mentioned, that some of the suspicion now has carryovers to areas where they should be able to trust the medications that are being suggested. Do we know what kind of messaging can actually work against that kind of inappropriate distrust, if I can put it that way?
I'm unaware of research programs that have successfully addressed that. But in this case of COVID-19 and the vaccine, I think there are some things that are in favor of overcoming distrust that's legitimate and existing. And one is just the very high efficacy of these vaccines. And then the other thing, I think that people's view of the vaccine has evolved over time and is still evolving, because if you are a person who has had COVID-19 or you have family members who have had COVID-19, I think that alone is going to have an impact on your interest in the vaccine. And you'll be able to see the importance of the vaccine. So maybe early on, where it wasn't as widespread, it's different than the situation now. And many people have multiple relatives who have COVID-19 or who have died of COVID-19. It's real. And so I think that that's going to have an impact and make it more acceptable. You're still going to need the right messaging, the right people to make the messages. You probably need to convince some barbers, of the importance of getting the vaccine, because the barbershop, as Howard has mentioned, is a place where African-American men gather, and it's a place where they feel safe and they can have these kinds of conversations. And if the barber is in favor of it, I think that could be very helpful. The other place that's been mentioned is the church. So if you have ministers who support it, then that's going to be positive. And churches or faith-based communities in general have been very supportive of health issues in the African-American community. And here in Philadelphia, we have ministers who have really taken a lead in terms of reducing health disparities affecting African-Americans.
That's great. Thank you, John. Maybe we've gotten, I should just say that I apologize to the audience. We're not going to be able to get to many of your questions, but we've gotten several questions that roughly are, and although I think we've addressed this, how do you find a balance between acknowledging, physiological and even genetic differences that are associated with race without falling into the trap of then looking as if we are saying that it's a difference that is inherent in minorities, inherent in Black people. More, I think. I just wanted to say that there's a lot of interest in that topic, although I think you have done a good job talking about how you can balance those two things, that saying that there are these differences is not the same thing as saying it's the fault of the person who is different. Both are different. And we also got some questions about pipeline issues, even though John's point has been well taken by the audience about it's also on whites to understand these and have cultural competencies. And I know, John, a lot of your work has been about cultural competencies, that it makes a certain intuitive sense that if we had more African-American doctors and nurses, that would go a long way to creating and spreading these. And so that issue really resonated with the audience. And I think we've talked a little bit about both the lack or not appropriate numbers in the medical profession of African Americans. But I think for a future topic, it might be interesting to know, do we have any ways of making that pipeline better? And we got a question that I thought was really interesting about, and this was really for Dr. Lewis, on the transmission of intergenerational stressors, so that some of the issues are the legacy of the kind of oppression that we've been talking about move from one generation to another, although they morph into different formats. And what role does it play in health disparities? And I don't know, as maybe a last word, Lisa, if you wanted to say anything about that particular topic.
Just really quickly, I mean, it's a good working theory, and I think there probably is some evidence to suggest, but I sort of wouldn't die on my hill to make a claim based on what I've seen so far.
Okay.
I think it's a good working theory, though, for sure. But I think we still need a little bit more work there to make that a solid claim. Maybe Dr. Spencer might have something to add as the person who does the biological work. But yeah.
Any thoughts on that, Quayshawn? Is that an area?
Sorry to put you on the spot.
Oh no. Philosophy don't come up with solutions. No. I actually do have something to say about how do you balance the some of the stuff, the biological determinants,
yeah.
determinants. I mean, to a certain extent, it's, we'll have to draw upon the expertise of our communications experts to figure that out. But also there's been some interesting research coming out of Brian Donovan and his lab, who works on how to do research that touches upon ancestry or genetic differences among racial groups without getting the negative sort of backlash of increasing racist attitudes or something like that. And one thing that popped up in his results that's very robust is if you start off individuals who are consuming this information with a higher competency in the relevant science, genetics in particular, then they have a much lower chance of imbibing that sort of message from the research. So in short, doing more education, right? Making sure that America is more literate in science seems to be one way we can guard against some of these negative consequences. There's some other concerns that some people had in the Q&A, which is like taking attention away from like the social structural sort of causes. And I'll push back on that and say, well, I think Howard and I and everyone on this panel have been pushing the same underlying cause, which is institutional racism.
Yeah.
And so it's not like,
Yeah.
we should, not pay attention to biological determinants and only look at social determinants because we're going to get at the majority of the social causes. Social causes are the same.
Yeah.
It's still racism. It's just the sort of racism I'm talking about is embedded in the study design of the science itself,
Sure.
right?
Yeah.
So if you're not tackling both, then I don't think we're going to get this sort of progress that we want to get with.
Well, and I will say that part of this whole discussion, which feels as if you've got to be careful about not going too far in that direction because it will be misunderstood, is part of the problem that we've been discussing about attitudes towards race, which is that somehow you need an oversimplified solution to the problem or explanation for the issue because people can't hold in their heads. Now I'm thinking about white people, the idea that both these things could be going on at the same time. And so that is part of the frustration of trying to deal with what is a very, very complicated issue, and one that we are not going to resolve today for sure, but this has been an outstanding discussion. And I just want to say a quick word before we say goodbye to thank the audience. First of all, thank the panelists for a great discussion. Secondly, to thank the audience for listening in and for your great questions, which I apologize that we couldn't get to in as much detail, but hopefully they were partially answered in the discussion. And to note that this is our last panel for this semester, but our next panel will continue the discussion of health and wellness disparities, looking more explicitly at health policies in the United States. And that'll be on Wednesday, January 27th from 5 to 6:15. We'll be sending out invitations to that as we get into the next year. But it's a great panel with Benoit Dubé, the Associate Provost and Chief Wellness Officer here at Penn, Zeke Emanuel, the Levy and Levy University Professor, Vice Provost for Global Initiatives, and also a member of President-elect Biden's COVID Advisory Board, Riza Lavizo-Moray, the Robert Wood Johnson Foundation PIK Professor of Health Policy and Health Equity, Jennifer Pra-Ruger, the Amartya Sen Professor of Health Equity, Economics and Policy in the School of Social Policy and Practice, and Eugenia South, Assistant Professor of Emergency Medicine in the Perelman School here at Penn. So it's another great panel. I hope you are able to attend. And once again, thank you all for a great panel. Thank you to the audience, and enjoy the rest of your evening. And hopefully I'll see you at the start of the new year. But thank you. Great job.